Good day, everyone. Welcome to the surgery ERPM session. This is a free introductory session in surgery. So I'll be discussing the further sessions after you registered. And I thought of doing trauma as a introductory session because you will be getting 4 or 5 MCQs, true false as well as single best answers in trauma. So trauma is more important, and I'll be doing like section wise in surgery, and I'll be discussing categorized MCQs, and finally the complete paper in surgery as well. Okay, the trauma, the primary survey is the important thing we should do. What is primary survey? Primary survey is organized according to the injuries that pose the most immediate threat to the life. Here, the injuries which cause the most immediate threat to life is considered the most priority injury which we should treat first. These also these are MCQ points because in primary the MCQ will occur like in primary survey. The least immediate threat is treated first. This is a false statement because the most immediate threat is treated first. So these are the key words, key things we should know in surgery. Regarding surgery exam, surgery is the easiest topic because there's a more we study more things, but they expect simple things, and most of the surgeons pass easily. They will give pass, and you don't need a thorough deep knowledge in surgery. A superficial knowledge is enough, and you should show that you are a safe doctor. In all exams, you should show that you are a safe doctor. So in primary survey, the most immediate threat to life is treated first. So it is performed in an order, or the patient should be accessed in the same manner. So all have to be accessed in the same manner. He is a higher official, so we have to treat him first. We can't differentiate patients like that. So the appropriate steps should be simultaneously taken. It's a parallel thing. It's not a vertical treatment, it's a horizontal treatment, because all the checkups, all the things will be carried out at the same time. Not like first we will do this, then after finishing it completely we will do the next step. Not like that. It is done simultaneously. If the patient deteriorates at any stage, the patient should be reassessed from the beginning. If deteriorate, again we should assess the patient from the beginning. Like A, B, C, D, E is the approach. This is the order. That means A means airway, and here cervical spine stabilization is the crucial point because the patient may be having cervical spine injury. So as a first step, we have to stabilize cervical spine. The next is breathing and ventilation for oxygen supply. And next is circulation. To control in circulation, we have to control hemorrhage. We have to maintain adequate end-organ perfusion. And then only after assessing ABC, we look where there's any disability, like in a stroke patient, where there's any neurological evaluation. A head injury patient, we have to do the basic neurological. It means complete neurological examination. And then the exposure, we have to undress the patient and search for any possible injuries. There may be hidden injuries, so we have to look for them. Okay, from the beginning, in the airway and cervical spine. Because airway obstruction can be occur even by a tongue, a foreign body, aspirated materials, tissue edema, or expanding hematoma. So it's very important that there's any airway obstruction. So if there's a airway obstruction, there will be inadequate ventilation, and there will be hypoxia where oxygen supply will be reduced, and the patient will die within minutes. A simple thing where we can save a life is the airway. So look for the airway and cervical spine at the very beginning. So initially we have to talk to the patient. No, we can ask what's your name like that. If the response is very accurate there, that means the patient can, if the patient can talk, the airway is better. Nothing problem in the airway. So that's okay. But in the unconscious patient, if he fell down and got unconscious, we can't expect reply. So in that situation, we don't know whether there is any airway obstruction or there. So we have to look for foreign bodies, so that we should open the mouth, and if there's a foreign body, we should remove by Magel's forceps. You don't need to know how to operate Magel's forceps for undergraduate level, but you should know that Magel's forceps is used in a trauma patient or anyone to remove foreign body. That's the thing is enough, and that's assessed in MCQs. Okay, and where there is any blood or fluid in the mouth, vomiters, we have to check that, because those all can obstruct the airway. Okay, then to maintain the airway, we have to do head tilt, chin lift, jaw thrust maneuver. So you might you have done your anesthesia appointment and surgery appointments. You might have experience, and you might have done all these things: head tilt, chin lift, jaw thrust. They won't ask how you are going to do in the exam, because these are exam-oriented teaching. But you have to know that these maneuvers are done to maintain airway. If we are suspecting that there's a cervical spine fracture, we just do jaw thrust and chin lift only. We don't do head tilt. This is an MCQ point. The head tilt is done first in a in a patient who had cervical fracture. It's a wrong statement, because we don't do head tilt. We just do jaw thrust and chin lift in a cervical spine fractured patient. So these are MCQ points. Cervical spine immobilization. So once we diagnose that there's a fracture, we have to immobilize cervical spine. So in a fracture management, the initial step is immobilization. It will be discussed in the future sessions. Assume injury to the cervical spine occurs in all blunt trauma patient until proven otherwise. So whether we don't know initially whether there's a cervical spine fracture or not, but we assume until proven otherwise that there's a cervical spine injury in all blunt trauma. Okay. Cervical collars are used to immobilize the spine, cervical spine. In Sri Lankan setup, we don't have enough facilities. So we use hard or semi-rigid cervical collar, which is known as Philadelphia collars. Is also these as an MCQs. We use sandbags or two-saline, but we don't have hi-fi strapping cervical collars in our government wards. So we use sandbags or two saline bottles either side of the neck to stabilize the neck, and we use a forehead strapping to strap the head without moving with a bed. Okay. These are used in Sri Lankan setup to immobilize cervical spine. You can't say cervical, the hi-fi cervical collars is used in your international, your foreign hospitals, because we, as a Sri Lankan setup, we don't use that because we don't have that. Once the airway has been cleared and secured, we can use Gordel airway, and we can use nasopharyngeal airway if there's no evidence of base of the skull fracture. Because if there is no evidence of base of the skull fracture only, we can use nasopharyngeal airway, because gag reflex won't be there if there is a head injury. So all patients should receive 100% oxygen, wear mask at a flow rate of 15 liter per minute. These flow rate and percentage are important for the exam purpose and also work during your house officer work. In a trauma patient with potentially difficult airway, if oral airways are unsuccessful, because if it is unsuccessful, we then go for cricothyroidectomy or endotracheal intubation. They will never ask how to put endotracheal tube, how to put cricothyroid in your MCQs, because these also are key topics. Okay. Then the next thing is breathing and ventilation. For the breathing and ventilation, we should assess the adequacy of oxygenation and ventilation, because hypoxia kills before hypovolemia. If the patient is severely bleeding, before bleeding kills the man, the hypoxia kills the patient. So if there's a clots, we should remove those clothes, because they will be tight and it will be obstructing. We should inspect the chest wall, looking for any signs of injuries, bruises, penetrating trauma, asymmetrical or paradoxical movements of the chest, because patient might be having flat chest, rib fractures. So if there's any crepitus, deformities, tracheal deviation in the chest, we have to palpate for them, and percus, whether it's hyperresonance or stonyidal, because it can cause hemothorax, pneumothorax, all will be discussed in further trauma sessions. And we have to do the auscultation, breathe for the breath sounds at the apices and axilla. The thorough respiratory system examination must be carried out to find any pathological things. Identify the immediate life-threatening conditions, and you have emergencies vivas as well. In emergency vivas, they will be asking this about the trauma. That means the immediate life-threatening conditions. You remember that immediate life-threatening conditions are tension pneumothorax, massive hemothorax, cardiac tamponade, like this. Don't tell all the injuries as immediate life-threatening conditions. That's false, and they don't expect crude answers. They always expect the picture-perfect brief answers. If a patient exhibiting signs of tension pneumothorax, we do needle decompression before imaging. Needle means if there's a small needle, we quickly pierce the chest wall and do the needle decompression in Sri Lankan setup. Okay. And how we can find whether the patient is having tension pneumothorax or not? The patient will be in hypotensive, dyspneic, and ipsilateral. Breath sounds reduces at the site of the pneumothorax, and trachea will be deviated to the opposite side. Okay, these are the four in the emergency where they will be asking what are the clinical things you will look in tension pneumothorax. You have to say all these four things. So the needle thoracocentesis. Needle thoracocentesis means it's a temporary decompression. This is not a permanent treatment, remember. So a large white bore needle is inserted. Where it is inserted, it's a second intercostal space in the midclavicular line. So how can you confirm? Then they will ask in the vivas, how can you confirm whether it's in the correct place? Then immediately after inserting the needle needle to save the life, immediately by the tube, we do thoracostomy. This is an IC tube. These IC tubes and drains, the life-saving method, this will come as a short case. So the IC tube, but the regarding things will be discussed in the short case sessions. Okay. Then we have to look for cardiac tamponade. Cardiac tamponade, the clinical signs, they are explained in Beck's triad. Beck's triad. The three things, if they ask in vivas, what are the things you will look in if you suspect cardiac tamponade? You will tell dilated neck veins, reduced blood pressure, increased ABP. Don't tell other things. And if you tell those other things, they will be asking more and more questions on that. So tell the correct thing quickly, briefly. So I'll be telling all the important points that you have to tell in the vivas as well as in your MCQs. So uh, listen to them and make a note for your exam. Okay. The next thing is circulation. For circulation, you have to perform an initial evaluation of the patient's circulatory system. By we can check always from history, examination, then only investigation. Don't jump into the investigation. Look for pulses per the examination. For the pulses, you can check the central pulses or peripheral pulses, pulse rate, blood pressure, and elicit whether there is a shock, whether the patient is having shock or not. While circulation is assessed, always, I always before said, this is not a vertical treatment. This is a horizontal or simultaneous treatment. So, while assessing the circulation, another person can insert two large bore cannula. We are inserting two large bore cannula so that if the patient is having severe hemorrhage, we can quickly transfer the fluids so that we insert two large bore cannula. Usually in Sri Lankan setup, 16 gauge, which is green, or orange color also can be used. Usually in the wards, it's hard to find orange color cannula, but it's easy to find green color cannula in Sri Lankan ward. So 16 gauge or below cannulas can be used. And this inserted to the anterior cubital fossa of both arms to transfer fluids very quickly. We take we take blood for investigation because trauma patient might be needing blood transfusion in the future. So we take blood for grouping and TT, which is the most important investigation in a trauma patient. Full blood count, urine electrolytes, those are things, but the main investigation is grouping and DT because we might be needing to transfuse blood. And normally 2 liters of normal saline is in fast bolus. Fast bolus mean according to Sri Lankan setup, 20 ml per kg is the fast bolus. Normal saline 2 liter is given. If there is a major external hemorrhage, a direct manual pressure is applied first to the patient. Then only the further treatment is done. First, direct manual pressure. These things are assessed in single best response questions. CVP line is not good to restore blood. So in trauma patients, initially we don't go for CVP line. So in trauma and CVs, don't mark CVP line as your answers at any cost because it's not a good to restore blood. It's because the central venous line is a small line because of the carbon dioxide vessels are usually collapsed, so we don't prefer CVP lines to restore fluids in a trauma patient. If severe ongoing blood loss is there, we should transfuse immediately with O negative blood because we can't readily get the grouping entity done and we can't get the matched blood. So we take O negative blood. Usually in Sri Lankan setup, it will take 5 minutes to get blood. So all those things should be taken under consideration when managing trauma patient because if we can, it will take 5 minutes to take blood from the blood bank and to give it to the patient. So meanwhile, we can give fluids. So like that, your management will change according to Sri Lankan resources. All fluids must be warmed before used to reduce the hypothermia. Okay, we can't give cold blood to the patient, which will induce hypothermia, and patient will die because of hypothermia before due to hypovolemia. If there's a significant hemorrhage occurs in any 5 sites, these are the important sites. There can be external hemorrhage by visual inspection. We can check for it, and local pressure is applied to reduce the bleeding. There can be intrathoracic, so we can do the ABC approach, chest X-ray, and to save the patient, we can do IC tube insertion. There can be intra-abdominal, retroperitoneal. So we should have to do the thorough clinical evaluation, and if we need, we might go for laparotomy. So these things will be explained in detail in abdominal respiratory, like system-wise trauma. There will be pelvic injuries or pelvic X-ray, bow splint test. Those are done. There may be long bone fractures or clinical examination, and then we can go for spontaneously traction and splintage for fracture management. The amount of blood loss in long bone fractures is more. It varies. If there's a humerus fracture, usually 0.5 liter blood loss. Femur, 1 to 1.5 liter. If it's a rib fracture, I mean one fracture at the rib, 150 ml. So we have to calculate number of fractures, and we have to calculate how much the patient has lost. And then you have to know the classes of the hemorrhagic shock. These are the common things asked in your emergencies vivas. There's a class 1, 2, 3, 4 shock, and the things assessed to classify the shock are blood loss in ml, and the blood loss percentage, pulse rate, blood pressure, pulse pressure, respiratory rate, urine output, and the central nervous system, the current state. So, according to the table, you should be thorough with this table, because in the vivas they will be giving case scenarios, and you should tell at which stage of shock the patient is currently on. If the blood loss is 750, it's 750, 1500, the category of shock varies. You should be thorough with this table. Okay. The circulatory response after infusion of 2 liters, because initially for the trauma patient, 2 liters of normal saline is infused. So by assessing the vital signs, we reassess the patient, and we come to a decision on the further management of the patient. So these are such graphs, but they won't ask them. If there is a blood loss less than 20%, that's normal, that's okay. If there's active bleeding, which means more than 20% of blood loss, they might require surgery. If there's no improvement in your pulse rate after 2 liters of normal, usually pulse rate is checked as a response. There's no improvements. Shock is not caused by hypovolemia, but it's due to, because there are many types of shock. It's not due to hypovolemic shock, but there's another shock that has caused. So we have to address which type of shock, and we have to manage accordingly. Patient is bleeding faster than infusion, which is if the blood loss is more than 40%, we have to thorough history examination and mechanism of injury, and we should assess. Okay, then you have to know about the FAST scan. FAST scan means focused assessment of sonography in trauma. This can confirm the abdominal bleeding. Clinical examination, chest X-ray, and these things are used to assess the site of bleeding. These things will be discussed in detail in the abdominal trauma module. Okay, and from the ABCD, the disability and the neurological evaluation is done. Here at the Sri Lankan setup, we do focused neurological examination. In our admission form in every government hospital, there will be, in the form, there will be AVPU. We don't there's no GCS in the admission form. In the admission form, it will be stated as ABPU, but we can calculate the GCS as well. But ABPU is already in the form, which means A means alert, P means response to voice, P means voice, where the patient can respond to voice, whether the patient can respond to pain, U mean unconscious. So we put where the patient is A or B or P or U at the admission time. This is a initial for examination, and we look for GCS as well. If this is a MCQ and SPR point, if the GCS is 8, less than 8, we should, it means better to intubate, because these are assessed in SPRs, like the patient presented with head injury, like the so on things, and his GCS is 7. What's the next best management? So if the GCS is given as less than 8, the first thing you have to do is intubation. Okay, because the normal the respiratory reflex is lost when the GCS is less than 8. So it's better to intubate. GCS is if you can't predict, because with severe brain injury, in some of the situation we can't predict the GCS. Such situations are severe brain injury, intubation, sedatives, when the patient is already drug intoxicated, we can predict the GCS. So maintain spinal immobilization for all the patients with the potential for spinal cord injury. We suspect that there might be spinal cord injury, so we maintain them, then maintain their spinal immobilization in all patients. If there's a motor deficit or if there's a spinal cord sensory level presentation, we should need we need to have any type of available imaging to look whether there are any intracranial bleeding or such. Then the next thing is exposure. All clothes should be removed and patient's entire body is examined for hidden injuries. Regions often neglected as usually due to hair, we might forget to check scalp, axillary folds, perineum, if the obese patient, abdominal folds. These are usually forgotten. So we should not forget these things, these areas to check. We have to do the thorough examination, and we should prevent hypothermia, because after removing all the clothes, the patient will experience hypothermia, and this hypothermia can contribute to coagulopathy, and it can develop multiple organ dysfunction. So we should be keen about development of hypothermia. So we should cover after examining. We can give blankets to cover the patient, and warm temperature at room is kept warm at 29.4 degrees Celsius at least, to prevent hypothermia in trauma patients. Okay, there are more diagnostic studies done for the trauma. For that diagnostic studies, we do radiographs, plain chest X-ray, lateral cervical spine, there, chest X-ray, pelvic X-ray. All the X-rays are not done in all the patients. We do investigation in a selected patient in a selected manner. That thing you need to know. That will be discussed when to do and when not to do the investigations in the later sessions. The later cervical spine, chest X-ray, pelvic X-ray can be done to detect any life-threatening injuries, and images of the if there's any penetration injury, like due to sharp injuries, we do imaging at the penetration site. Another thing is FAST scan. Okay, they will be asking what are the areas we look at the FAST scan. So you should know the 4 areas are checked. One is your pericardium. Pericardium is checked. Then your right upper quadrant, your Morrison's pouch is checked. Pelvis is checked, and the splenorenal, and the perisplenal spaces are checked. These are the 4 areas, 4 sites checked in the fast scan. They usually ask this in the vivas. The essential part of primary circulation survey is an unstable patient. It's a fast scan. This is essential in unstable patient because they can't convey their injuries. So by scan only we can come to know the size injury. Primarily, these fast scans used primarily to detect pericardial and intraperitoneal bleeding. It's more accurate for detecting intra-abdominal injury. Hemodynamically stable patients, fast scan can be delayed because unnecessary investigation. If the patient is hemodynamically stable, we don't need to do fast scan as an initial investigation until secondary survey is completed. There's a primary survey, then only we go for secondary survey. So until secondary survey is completed, if the patient is hemodynamically stable, we don't need to do fast scan. These are SPR points. Less sensitive for detecting these fast scans, less sensitive for detecting pelvic bleeding, and we cannot differentiate whether it's blood or urine in the pelvis with the fast scan. Okay, so we don't rely on fast scan when there's a pelvic bleeding. Retroperitoneal also, it won't be reliable because it's anyway ultrasound scan. Retroperitoneal organs cannot be seen clearly in an ultrasound scan. Less sensitivity for penetrating trauma than blunt trauma. It's less sensitivity in penetrating trauma. So there are advantages as well as disadvantages regarding fast scan. So they will be asking these things in Viva. So if you know these points, that's enough to pass the exam. And CT scan also done if needed. If the patient is hemodynamically unstable and the source of bleeding cannot be found in your above scans after resuscitation, usually CT image is done. After resuscitation, only CT scan. Don't jump CT scan as a first. After resuscitation, that means ABC, only you do CT imaging. Sometime before emergency surgeries, we go for CT scan because these are expensive investigations. So we don't do without indication. Then diagnostic peritoneal lavage. This is not used nowadays in Sri Lankan setup. If the unstable patient if the source of bleeding is not found, usually in the good old days, diagnostic peritoneal lavage is performed. But it is performed to detect intraperitoneal blood if fast scan is not available, usually in the teaching hospitals and district hospitals, we have fast scan. But in base hospitals, they might not be having fast scan in Sri Lankan setup. In that scenario, they might be using diagnostic peritoneal lavage. But this is far more replaced by fast scan nowadays. And this is all about the primary survey, and the secondary survey will be continued in my future sessions, and again the categorized MCQs papers will be discussed. History taking will be discussed in the future sessions. If you want to know about future sessions and if you want to register, please contact my WhatsApp. This is my WhatsApp number. Okay, and that's all for the introductory session, and thank you.